Welcome to the first webinar after the summer. As a matter of fact, we have winter here at the moment because there's a lot of snow that we have in Vienna and Christmas is coming up. So it's a pleasure to invite someone who comes from the cold as well. Elena Surkova, she's from Russia, but of course she was trained in Padua, she was trained in London, and she was also in Vienna with us. So welcome.
Thank you very much, Thomas. It's a great pleasure for me, as usual, to be here and to watch together some interesting cases.
Yes, we have a number of cases for you prepared and also a special little lecture, which I think will be very inspiring and something that you will definitely need in your practice. Before I start with the webinar and the cases, I want to make a quick announcement because we've been quite busy and we've been working on a new front this time. We actually produced a new course, a course which deals with ultrasound, obviously, but not only with a specific area of ultrasound, but actually with point-of-care ultrasound. So here, we're going to show different modalities of ultrasound that you can use in your practice. Actually, it's targeted to people who want to use it on the forefront of medicine. And it's also a great product if you want to learn other modalities very easily. So here is a short trailer to show you what this course is all about. So if you're interested, you can go to our webpage and get more information on this course. Now let's jump right into the very first case. A case where we'll be dealing with the timing of surgery in a patient with mitral valve disease. As a matter of fact, as you can clearly see here, severe mitral regurgitation. Elena, maybe do you want to make a few comments on the mitral regurgitation we see here?
Yes, so on the 2D image we can see four-chamber view, and you can probably spot the pathology right now. Pay some attention to the motion of the mitral valve leaflets, and also to the hyperdynamic function of the left ventricle, which is very typical for patients with significant mitral regurgitation. And of course, if you can look at the color Doppler image, you can clearly see very impressive severe mitral regurgitation.
Yes, I think the degree of mitral regurgitation is easy to quantify visually. Of course, if you have other modalities of hand where you can look at the regurgitant orifice area, or regurgitant fraction, then that would be, of course, an additional value. But I guess the severity is quite clear. Since you're an expert on the right ventricle, do you maybe want to comment on the right ventricle as well?
Well, for me, the right ventricle looks pretty good here. We can see that the longitudinal function and the displacement of the tricuspid annulus is really prominent in this patient. And, well, radial contraction is also preserved, so I would definitely say it's normal right ventricle.
Right, I would agree. Let's focus again on the left ventricle. Oh, by the way, if you have any questions, you can always ask these questions. You can put them in your little chat box, and we'll be glad to answer them either during the webinar or even after the webinar. So here is the left ventricle now. Since this patient has severe mitral regurgitation, and let's say the patient is asymptomatic, we will have the question whether or not this patient actually needs cardiovascular surgery. So here we'll be looking at additional findings. For example, the size of the left ventricle, the function of the left ventricle, specifically also the end systolic diameter. So you already mentioned that left ventricle function is normal. But Elena, what is the specific thing we have to watch out in the setting of mitral regurgitation?
Well, we have to remember that ejection fraction is a load-dependent parameter. And in patients with severe mitral regurgitation, we can overestimate the real true ejection fraction if we just base on the normal calculation of the ejection fraction using Simpson or any other techniques.
Right.
So, for example, probably the ejection fraction of 55–60% is not so great for patients with severe mitral regurgitation.
Right, and as a matter of fact, in the guidelines, we have a cutoff value of 60 for ejection fraction. If it's below, then it already means that there's some form of systolic dysfunction. The diameter of the ventricle is not huge. It's definitely not above 70 millimeters, and the end systolic diameter is also, I'd say, relatively small. So these criteria are all not in place to put the patient to cardiovascular surgery as long as he is asymptomatic. Now, here is the speckle tracking pattern that the analysis that we performed in this patient. Maybe, Elena, for those who are not so familiar with speckle tracking, can you just briefly summarize what we're doing here?
Yes, of course. So speckle tracking helps us to analyze the deformation of myocardium. And now we are talking 2D longitudinal speckle tracking strain. So we assess the longitudinal deformation, longitudinal shortening of the myocardium during systole in 3 apical views, in 4-chamber, 2-chamber, and 3-chamber view. And at the bottom of the screen, we can see the result of the analysis. This is so-called bull-eye plot. And we can see the segmental values, and also there is a color coding, and we can clearly see that all segments are colored red, which means that this is a normal strain.
Yeah. So the nice thing about this bullseye display is that in one glance you get a very good impression of global function and also regional function. The red color means everything is good, so Red Bull is good.
Yes.
Okay? So, of course, not the drink, but at least this Red Bull is good. We got a question from Ahmed, which I want to answer, and he wants to know, does this patient need emergency surgery? Well, a good question. Well, if you look at these images, you probably cannot tell because it would definitely need you to know what his symptoms are. In this situation, as I mentioned, he was asymptomatic, so there's no need to really operate him surgically. We're in a category of patients now where we have to decide if someone who is asymptomatic should be operated. And this is exactly why we're performing all these calculations and measurements to determine if he is a candidate for surgery at this point already. If we look at the morphology of the valve, we've got a prolapse. So this would definitely be something that you could repair, but also depending on how many segments are actually involved. If it is an extensive mitral valve prolapse, then it's more difficult to repair. And this is important for the decision as well, because we should only go to surgery in asymptomatic patients if there's a high likelihood of mitral valve repair.
I completely agree. And it's very nice showing the specific motion of the basal segment of inferior lateral wall in 3-chamber view, so-called inferior basal curling, very specific for mitral valve prolapse.
Right. This is what we also call the rocking motion of the basal part of the septum, or they also call it atrioventricular, what's the term again? There's a special term for that as well. But whatever you describe it, whatever name you give it, important that you see this motion very frequently in patients with mitral valve prolapse. Now, Kudat wants to know, is that a primary or secondary MR? Do you want to answer that maybe?
Yes, of course. So there is a classical classification. The mitral regurgitation could be caused by the problems of mitral valve leaflets, like in this patient, for example, the mitral valve prolapse, and we call it primary regurgitation, primary MR. Or the second mechanism may be the annual dilatation, for example, when the mitral valve leaflets are completely normal. However, there is a significant mitral regurgitation caused by other reasons, and then we call it secondary MR. Yes. And in this case, obviously, it's primary mitral regurgitation because of mitral valve prolapse.
Yes. I mean, in many cases, even in primary mitral regurgitation, there's some component of annual dilatation as well, because the ventricle dilates if you have MR, but we would still call this a primary MR. But coming back now again to the bullseye display. So we've got everything red, and if we calculate the global longitudinal strain, which is the mean value of all the segments, we get a value of -21.4, which is a normal global longitudinal strain. As a matter of fact, it's almost a hyperdynamic longitudinal strain, which is good for the patient because it mirrors that the patient has hyperdynamic function and that the ventricle is doing fine. Good. So I think the nice thing about this bullseye display is that we can be very sure that together with the other findings, this patient does not need surgery unless the patient definitely wants to have the surgery and we have a good surgeon at hand. So this was the study that we performed, but this is the follow-up study that was performed 8 months later. Now, what do we see here?
Well, here we can see from the first glance completely differently looking bull eye, and now it's already not fully red. There are some red parts in the apical and mid segments. However, we can see that anteroseptal, lateral segments, and the part of inferoseptal segments are pink. So it means that the segmental strain values are decreased. Tommy, can you comment about global longitudinal strain in this patient?
Yes, I think the global longitudinal strain was now minus, I think, 16.5, so it's definitely reduced. And there's something else that we see here. We see that there's actually now also a flare leaflet. We see that the leaflet has ruptured, and that this has caused, of course, further deterioration of, or let's put it this way, that has, of course, caused further impairment of increasing mitral regurgitation and thereby impairment of left ventricular function. The nice thing, however, is that we see a reduction in strain not only globally, but specifically at the base of the heart. This is a very frequent finding. If left ventricular function starts to deteriorate, it usually deteriorates first at the base. Now, with this finding, I guess you definitely need to go to surgery. Not only based on the strain, because that is not in the guidelines yet, but actually more based on the fact that the patient was getting symptomatic. And we performed mitral valve repair in this patient, and now you see the result after mitral valve repair, actually. Do you want to comment on the ventricle, maybe, on ventricular function?
Yes, of course. Even from 2D images, we can see that now already ejection fraction is reduced. How would you approximately estimate it?
Yes, there's a little bit of an abnormal septal motion as well. You see that very frequently after operation, and that makes it a little bit more difficult to assess global left ventricular function. But I would say it is reduced, and I would probably say it's mild to moderately reduced, maybe even moderately reduced. So we have the situation that we actually are afraid to have, namely that patients after surgery, once afterload increases because we're closing the leak, now have a significant reduction in left ventricular function.
And also, if we look at the bull-eye plot for the global strain and segmental strain analysis, now this picture looks completely different, and we have a lot of regions with pink color, meaning reduced longitudinal strain.
Right, so you can nicely see how you can follow these patients and get a very good handle on the function of the ventricle. But which is even more intriguing, and let me go back to the study that was performed preoperatively, I think in this situation you would probably say the patient has normal ejection fraction. And he did. It was over 60%. Nevertheless, we already see a reduction in strain. So it is somehow the assumption that global longitudinal strain could be a very good predictor of left ventricular deterioration, also in mitral regurgitation, and that possibly we can use speckle tracking maybe for the timing of cardiovascular surgery. Now, what is your take on this? Should we use it, or is this maybe too early to do?
I think from practical point of view, it's very important technique, because again, as it's nicely illustrated here, in this case, in the first image, only global longitudinal strain was telling us something wrong with this left ventricle, because ejection fraction was completely normal. So this technique allows us to note very early markers of LV dysfunction.
I think one of the problems we have at present is that there is no clear cutoff value that we can really define where we say from this value on we should bring the patient to surgery. It's my personal opinion that I don't think that it really makes sense to put a certain value as a cutoff, a limit, but probably more to look at the course of the patient with respect to longitudinal strain. And if you see that there's a gradual decrease, then that might be the time when you should start thinking of really operating the patient. But I guess in conclusion, this case just so nicely illustrates the value of longitudinal strain. And if you compare again the different values of strain we had in this patient, you see that it deteriorated over time. And this is the post-operative study, which was even less than I mentioned previously, was only 13.6, which probably also means that the patient does not have a normal prognosis after cardiovascular surgery. Good, so this case highlights the importance of strain. And of course, we are very, very keen to also announce our speckle tracking course, something we've been working on for now over a year. We've invited many, many speakers. And we've, of course, have Elena Surkova with us. She'll be talking about right ventricle strain in our course. And I just want to shortly show you a very short trailer that we produced just to make you hungry for strain.
I think speckle tracking is a really unique tool.
I think today we should really use strain in everyday clinical practice.
Strain is a new technology that's absolutely ready for prime time.
The potential of speckle tracking is huge.
I would be using it in a lot of clinical scenarios.
It gives you an objective and quantifiable view on cardiac function.
Strain is very fast, it's very robust.
It's not very time-consuming, so in the busy environment of EchoLab, it gives a lot of help with the price of little time.
It's really important to every echocardiographer to learn how to use it.
What is speckle tracking all about? Basically, it's another way of looking at cardiac function, but this time on the level of the myocardial fibers. In other words, how well the muscle actually contracts. It's actually quite simple to analyze a speckle tracking image, especially if you're using the so-called automated functional imaging program, which is built into the machine. I would recommend that you start with a pulsed wave Doppler, because here you can actually define when aortic valve opening and aortic valve closure is.
Take care of a good ECG, because without an ECG you cannot trigger your loops, especially for advanced applications such as speckle tracking imaging.
The contour was found quite nicely. If you're not happy, you can reanalyze it. We have all the three apical views that we were using. We've got the bullseye display. We have minus 20.4, which denotes a completely normal longitudinal strain. Frequently, at least in my experience, you will see more involvement with respect to strain as you can actually see with the eye.
So now I want to show you the resulting bullseye plot, and this is the complete analysis of the left ventricle. We have a global longitudinal strain which is below 9%, so severely depressed longitudinal function.
Here we see two segments belonging to the lateral wall with systolic stretch and a diastolic shortening. This clearly indicates the presence of viability.
Here is the strain analysis of our patient. Did you expect such a poor strain, which is so regionally distributed as in this bullseye display?
I would like to share with you some tips, some very simple things which we can assess by echocardiography, which can help us assessing the mechanics of left ventricle. The specific longitudinal strain pattern had been described recently. It includes three major points.
So basically, if you have this pattern, it would be typical for the classic type of left bundle branch block, where you would also see the septal flash. Remember, patients frequently develop hypertrophic cardiomyopathy during their life, and you might catch them in an early phase where the hypertrophy might not be really so prominent. So what you're saying here is that with speckle tracking, we can detect it at such an early stage before hypertrophy is really overt?
Yes, and I think we should open this diagnostic tool not only to the patients but also to their families. In patients with hypertrophic cardiomyopathy, we have a reduced global strain, but also let's look at the temporal function, and you can see some dyssynchrony in the patients with hypertrophic cardiomyopathy.
So in summary, as you can see, if you combine the information, the bullseye display, with the curves, you can get a lot of information which will be very valuable in specific clinical situations. You'll see another case where we deal with speckle tracking a little bit later. I do want to answer two questions before we come to Elena's case. And one question from Larry was, is there dyssynchrony in the left ventricle? Do you think there was dyssynchrony? Let's go back to this case once more and let's see.
Well, if we just visually appreciate the dyssynchrony, I would say there is no significant dyssynchrony. For me, the contraction pattern of this left ventricle is pretty synchronous.
Yes. We also have a normal QRS complex width, and if you observe the septum and the lateral wall, they seem to be contracting at the same time. And then there's a question by Jorge. What to do if the diameter of the left ventricle is still normal, the patient is asymptomatic, but strain is impaired? I think we talked about that, and at this present time, it's nothing that we can really, let's put it this way, it's not in the guidelines yet. But as I mentioned, I think it's still a good parameter to use to look at whether or not strain is deteriorating over time. And then a question by Perver, what happens to the ejection fraction after a patient is operated with mitral regurgitation? Well, ideally, it should be still normal. It usually drops to some degree, but it should still be normal. This would be the optimal situation. But as you saw in the previous case, this sometimes is not the case, and that kind of makes me thinking if we are not sometimes operating patients too late. But we know that a strain after operation, which is reduced, is also associated with a worse prognosis. All of these things point in the right direction. Good, now let's go to the first case that Elena wants to show us, and we will call this case moving right. Why?
Thank you, Thomas. Okay, now we will talk a little bit about the right heart. So this is the clinical case. It's 67 years old male patient. He had a clinical history of coronary artery disease, non-significant carotid artery atherosclerosis, and a month ago he was admitted with non-STEMI. This is the coronary angiography, and I would like to focus on right coronary artery. For your information, the patient has significant three-vessel coronary artery disease. But today we are going to talk about right ventricle, so please have a look at the right coronary artery problems, and you can clearly see that there is significant stenosis in the first part of the coronary artery, in the first segment, and in the distal segment. So definitely the circulation in the region of right coronary artery should be abnormal. Okay, and this is the echocardiography. I would like you to look at these images and first try to think about left ventricular wall motion abnormalities. Well, absolutely clear, we can see abnormal akinetic region in the two-chamber view in the basal and mid-inferior wall. Also, we can appreciate the abnormal motion of basal interventricular septum in the four-chamber view, and some degree of abnormal motion, I would say probably severe hyperkinesia, in the inferolateral wall. Okay, all these findings help us to suspect again some problems with the right coronary artery first. And now please have a look at four-chamber view. My question to you, whether the right ventricle is dilated or not, and what do you think about the function of both ventricles, right ventricle and left ventricle? Let me start from the first question. From this view, I would say that the right ventricle is not larger than left ventricle. Do you agree?
Yes, I absolutely agree. Maybe you want to comment why this is important?
Yes, because for patients with inferior myocardial infarction, keeping in mind the fact that the right coronary artery is the same artery responsible for left ventricular inferior infarctions and right ventricular infarctions, it's very important to assess right ventricle very carefully because it's an important prognostic marker. And if the patients with inferior myocardial infarction have involvement of the right ventricle, they normally have worse prognosis. So from this view, we cannot say if the right ventricle is dilated or not. At least it's not more than left ventricle, which is a good sign probably. Let us move to the quantification, and first we perform the 3D echocardiographic analysis of the left ventricle, and now we can see that the left ventricle actually is dilated. The end diastolic volume is 204 milliliters. Well, and obviously it's dysfunction. The ejection fraction is only 38%. And again, coming back to the right ventricle, yes, right ventricle is not larger than left ventricle in four-chamber view. However, we still do not know if it's normal or not, because the left ventricle is dilated. Let us have a look at the RV-focused four-chamber view. And my questions to you are the same. Is this right ventricle dilated or not? And what do you think about the RV systolic function? Let us perform some measurements. These are two-dimensional diameters of the right ventricle. And as you can see, the basal diameter is 43 millimeters, which is slightly dilated. The reference value is 41. However, the mid diameter is completely normal. And again, we have to remember that this is just two-dimensional technique. We have absolutely no information about RVOT size and function, about all other parts of the right ventricle. So basing on these images only, again, we cannot be absolutely sure about the size of the right ventricle.
Let me ask you a question. Do you perform always two measurements of the right ventricle? Is that what you would do?
Normally in the guidelines, we have several measurements recommended to assess the size of the right ventricle. These are diameters obtained from apical four-chamber view and parasternal short axis and long axis view. Normally, I would prefer to perform basal and mid diameters in apical four-chamber view, but also we have to assess end diastolic area of the right ventricle, and ideally, we would like to go for 3D echocardiographic analysis because, as we will see later, this is the most accurate technique. Now let us look at the systolic function of the right ventricle, and first of all, the conventional parameters of systolic function. Here you can clearly see that TAPSI and S prime are completely normal. TAPSI is 18 millimeters and S prime is 12 meters per second. So this is absolutely normal value. However, if we perform the quantification of fractional area change, we can see that this parameter is reduced. It's just 30%, with the reference value 35 and more. So now we have the discrepancy between conventional parameters of RV systolic function.
I think this is something we see quite frequently, actually. You know, it would be ideal if other parameters show in the same direction, but they frequently don't. And I think there's a number of reasons for this, but I'll let Elena talk about this. But be aware that all of these parameters say something a little bit different.
Yes, let me to summarize at this point our findings. So the patient with inferior left myocardial infarction with slightly dilated basal diameter of the right ventricle and discrepancy in findings in the systolic function of the right ventricle measured by conventional parameters. What do we need to go next? Okay, let's go for the more sophisticated echocardiographic techniques. First of all, we have performed strain analysis, and here you can see the results. Okay, global longitudinal strain is minus 17.1, which is slightly reduced. However, as you can see, and if you wish to calculate the RV free wall longitudinal strain, it's minus 23%.
Elena, can you explain what the difference between these two is?
There are different techniques. How do we measure that? So when we measure global longitudinal strain, we include in the analysis both RV free wall and interventricular septum, as you can see here in the picture. So we have 6 segments, 3 for RV free wall and 3 for interventricular septum. When we perform only RV free wall longitudinal strain analysis, we analyze only RV free wall and 3 segments. In this case, it was just calculated as an arithmetic mean of 3 segmental values, 21, 27, and 21 again.
Right. I mean, the discussion in the literature for those who are maybe not so familiar with the problem of right ventricle strain is, should we take parts of the septum which actually also belong to the left ventricle? Is that also a good correlate of right ventricle function? I think this discussion is not over at this point. What is your take here?
Well, I would say that interventricular septum is an important contributor of RV systolic function as well. And we know that 20–30% of the ejection fraction of the right ventricle is due to the interventricular septum function and LV function. And we have a lot of examples showing the RV dysfunction in patients with severe impairment of LV function.
Yeah. But specifically, if you have a problem of the left ventricle, for example, wouldn't that also somehow influence your right ventricular strain?
Yes, obviously, like in these patients, you can see that we have the left ventricular problems, and now the septal strain is significantly reduced in comparison with RV free wall. Right. But what do we know about reference values for strain? Let us have a look. In the recent cardiac chamber guidelines, published 2 years ago, there is a cutoff value for RV free wall longitudinal strain, minus 20%. Which is, I would say, pretty low, because a year after that, in 2016, the currently largest reference study had been published. And here you can see that the reference value for global longitudinal strain, for 6-segment strain, has the low limit of normality, minus 20, and the reference value for 3 segments free wall RV strain has the lower limits of normality, minus 23. And coming back to our patient, he has the RV free wall longitudinal strain, minus 23, which I would probably say low normal. And then we move to the next relatively new technique, 3D echocardiography. Here you can see multi-slice, 12-slice display, and you can nicely see the right ventricle in 3 long axis view and 9 short axis view. Why do we need this image, this display? It helps us to evaluate the regional wall motion of the right ventricle, and you can clearly see that the motion of the RV free wall is slightly hyperkinetic. We can also perform the volumetric analysis of this patient, and this is the final result. So end-diastolic volume was 194 milliliters, and giving body surface area 2, we can say that this right ventricle is dilated, and ejection fraction was only 40, with the reference value 45 and more. So our conclusion, this right ventricle is dilated and dysfunctioned.
Yeah. So a beautiful example of the advantage of 3D echocardiography in looking at the exact volumes. Could you maybe just explain a little bit about the shape of the right ventricle, because this is a kind of an awkward structure here?
Well, right ventricle has 3 anatomical components. The first one is RV inflow, close to tricuspid valve, yes, which we can see here. Also RV apex, RV outflow, close to pulmonary valve. We can also see the interventricular septum and the motion of interventricular septum during systole and diastole. And well, when we perform the analysis of 3D RV volumes and ejection fraction, we used to compare our values with cardiac magnetic resonance, which is still the gold standard for volumetric analysis of the right ventricle. And in this example, you can clearly see that despite the fact that CMR-derived volumes are slightly larger than those which we got using 3D echocardiography, which is actually normal finding due to different spatial resolution of the technique, the ejection fraction is absolutely the same.
Yeah, so very good correlation with the 3D and MR, and I think that has been shown in many studies that they correlate quite well. And sometimes I wonder, what should really be the gold standard Should it be echo or should it be MR?
Well, it's a tricky question, Tommy, because for me, being a big fan of 3D echocardiography, I would say that 3D echo is a brilliant technique for assessment of the right ventricle, however, in patients with good acoustic window, and that's the main problem. CMR has its own limitation, like position of the basal slice and so on and so forth. However, still, now we have two powerful techniques in our hand to evaluate the volumes and ejection fraction. Here we can nicely see the reason for the discrepancy in conventional parameters of RV systolic function. Just to help you understand these images, the white cage on the images represent the end diastolic frame and diastolic volume of the right ventricle, and the green shape, green figure illustrates in these images end systolic frame and end systolic volume. And you can clearly see that despite the fact that longitudinal function is relatively preserved, the radial contraction and the displacement of RV free wall is very, very poor, and that's why, in total, we have reduced ejection fraction and reduced systolic function. Let us review the reference values of 3D echocardiography volumes of the right ventricle. First of all, we have to remember that they are different for different genders. And these are the values published in the recent guidelines. So remember these numbers, 87 milliliters per meter square for men and 74 for women. However, ejection fraction is the same for different gender. And we have to remember that ejection fraction below 45% should be considered as abnormal. Even more, RV volumes depend not only on gender, but also on age. We do not have these differences in the current guidelines just to make our clinical routine less complicated. However, we have to remember this fact, and probably if our patient is too elderly, probably 78 is too much for him. Just some information about what we can get from the same 3D dataset in the same patient, just perform very short post-processing. Okay, we can nicely see the valves, the mitral valve, tricuspid valve. We can appreciate the leaflets motion, the annulus. We can also nicely see RVOT, and at least visually appreciate the systolic function of the RVOT and contribution of the RVOT in the global systolic function of the right ventricle. And we can nicely see interventricular septum and appreciate the motion of interventricular septum. In this patient, it's completely normal. However, it's very important and abnormal in patients with pressure or volume overload of the right ventricle.
I think those are just such spectacular images that Elena brought with us. To be honest, of course, you will not get this in every patient, but I don't know of any images which really can compare to those you always bring with us. And it's so intriguing to look at these images because aside from the fact that it will help us in volumes and looking at morphology, I think you get such a much better understanding of the anatomy. I do want to highlight something. I mean, you must imagine we're cutting the tip of the ventricle away. Now we're looking from the ventricle directly towards the valves, and you can so nicely see that the blood is coming from down up into the ventricle, and then turning around and going into the right ventricular outflow tract. So you can almost see this crescent, you know, the region that differentiates the inflow from the outflow tract. So this is a spectacular image.
Thank you, Thomas. And let me move to the take-home messages of this clinical case. Okay, 3D echocardiography has a number of advantages in the assessment of the right ventricular size and function. First of all, this is the only echocardiographic technique which permits quantification of RV volumes and ejection fraction. It incorporates all three components of the right ventricle in a single dataset, and that's why it has no geometrical assumptions about RV shape, does not use any formula for calculation of RV systolic function or size. There are established clinical indications already. We should use 3D echocardiography for measurement of RV volumes and the calculation of RV ejection fraction, especially in patients for whom the information about the right ventricle is clinically or prognostically important. So these are patients with pulmonary hypertension, congenital heart disease, coronary artery disease, myocardial infarction, and other RV pathology and failure. And just to remind you, in the current guidelines, there is a statement that in the laboratories with experience in 3D echocardiography and in patients when the knowledge about RV volumes and function are clinically important, 3D measurements of RV volumes and ejection fraction is recommended.
Right. So, Elena, thank you very much for this beautiful overview. One last question I have to you. Why does the patient have poor right ventricle function?
Well, this patient again has 3-vessel coronary artery disease with the involvement of the right coronary artery, and I would suspect 2 mechanisms. So first, the problem of the RV myocardium, the ischemic problems in the RV myocardium, but also due to the poor function of the left ventricle due to interventricular interdependence.
Okay, so the issue of coronary artery disease, especially infarcts of the right coronary artery, and right ventricle dysfunction is a very important one. Do you know how frequently do we actually see involvement of the right ventricle, especially if you look at methodologies like strain? Does that help us in determining if the right ventricle has also been impaired?
It's pretty frequent finding, and in numerous papers it has been highlighted that we must carefully assess RV function in patients with inferior LV infarction. And in recently published paper, there is even a cutoff value for RV global longitudinal strain, minus 15.5%, and the strain values below this cutoff are important prognostic markers of adverse events. The patients had been followed for 4 to 5 years in this paper. And the prognostic importance of this marker was additional to those provided by age, LV function, and other clinical signs.
Yeah, such an important point. If you have patients with myocardial infarction, especially inferior infarcts, always look at the right ventricle. And I think the right ventricular infarcts are probably underdiagnosed in many patient populations. Good. So before we come to the next case, we have a few questions queued up. I want to answer them. Clarissa wants to know regarding the last case, what about the symptoms after surgery? Well, the patient had a very slow recovery, which is often very typical of patients who do not have normal left ventricle function after operation. Of course, I did not see her in the long-time follow-up yet because surgery was only performed a few months ago or so. But in principle, I would assume that this patient does not have normal exercise capacity. And then the question from Ali was, I think it's more a general question, which I would love to answer as well. If there is an angulation between the ascending aorta and the interventricular septum in the peristernal long axis view, then the M-mode measurements are false. Do you want to comment on that?
Well, I would start from the fact that M-mode measurements are not currently recommended, and it's always better to use B-mode 2D measurements in order to position our diameters absolutely perpendicular to the borders of the structure we measure.
Yes. I also have a very strong opinion on this. Personally, I believe that there are many things which are still in textbooks and in some publications which are absolutely true. Of course, if you have an angle and you, of course, have a different transection of the ventricle, you will probably overestimate the size. But I think the issue is we have to sort out some of these things because we have so many new modalities which provide so much more information. I would just not use the MO to look at left ventricular size, and this is something that's in the guidelines as well. And Atsubuki wants to know what about the dyssynchrony in the patient again in the case before after post-operatively. Yes, I mentioned that already. Yes, the patient does have, I would not call it dyssynchrony. He has abnormal septal motion. This is something you see quite frequently after operation, and there's been always some speculation why you see this. The current thought is that it has to do with opening of the pericardium, which in some way affects also the motion of the septum. Jorge is asking, in pulmonary embolism scenario, TAPSE or strain or right ventricle function, what would you choose to assess this prognosis? I think I'll throw this question to you.
Okay, we remember that the most parameters, conventional parameters of RV systolic function are load dependent. Unfortunately, the same problem has 3D echo-derived ejection fraction. And there are a number of papers showing the prognostic significance of main parameters like TAPSE or S prime. But I would definitely go to more novel techniques like strain or 3D echo ejection fraction of the right ventricle.
Yeah. And I can give you my answer. It's very simple, strain. Okay. CNAT, do we have to add a software in G, Vivid 1 or Vivid 7, I guess, for speckled tracking? Well, you know, I don't think, of course, I can answer all these vendor questions, but this is a very easy one. A lot of vendors have the software for speckled tracking implemented in their scanners. It's usually an add-on. Frequently, you just need a key to open it so that you can use it. Of course, it requires more newer machines, but there are also some vendors that are independent of special ultrasound producing companies where you simply export the images from the machine, from the scanner, and import it into this software, and then you can also perform a strain analysis. So there are a number of different ways you can do it. Good, let's move on now, and let's go to our next case. This is a case that has a format that we are using in one of our teaching modules, which is called Echo to Go. Let me tell you a little bit about this format before I show you this case. The idea behind it is that we want to give you the option to learn on the go, that we provide relatively short teaching units, and also engaging you by asking a question, and then also getting not only the answer, but some feedback. We are here in the studio now, and before we started the webinar, we actually had some Echo to Go questions that we were preparing, and we want to show you live now how such an Echo to Go question actually works. So we usually start with a question, and the question in this case is,
which cardiovascular procedure was performed in this patient? Is it aortic valve replacement, myectomy, heart transplantation, alcohol septal ablation, or atrial septal defect closure?
Right, so this is the question. Of course, to answer this question, you need some more information, and specifically, you need an echo.
Okay, here we can see parasternal long axis view, 2D image, and color Doppler image. Tell me how you can comment these images. Are there any pathologies here?
Well, up front, to be honest, I'm not 100% happy with the image that actually I took, because I would probably prefer to put the sector once on the aortic valve and once on the mitral valve. Here I'm using a compromise. I'm using both valves. But I guess the point here is to demonstrate that there's a little bit of mitral regurgitation and probably no aortic regurgitation.
Here we can also appreciate the contraction of the left ventricle, the motion of the leaflets of the valve, the structure of the leaflets.
What about left ventricular hypertrophy?
Visually, yes. I would say there is some degree of LV hypertrophy. We need to measure for more careful estimation.
Yes, definitely there was, somewhere in the range of 12 to 13 millimeters.
Let us look at four-chamber view. Again, we can see main cardiac structures here, left ventricle, right ventricle, both atria.
Now the atria, especially the left atrium, looks a little bit enlarged. Keep this in mind when you want to answer the question. Also look at the structures which are maybe around the heart.
Okay, let us move to the next images. And again, three-chamber view and four-chamber view with color. And as we noted from the parasternal long axis view, there is some degree of mitral regurgitation.
Okay. And now we'll move to the speckled tracking or strain pattern. You know probably already from many of the cases we presented previously that this is the bullseye display. We have the global longitudinal strain right here, which is minus 15.3. We see that there is probably normal strain here at the apex and a reduction in strain at the base. So this is not a completely normal speckled tracking pattern. Now we have diastolic function. We can see that the E wave is relatively high, the A wave is relatively low. It's a ratio above 2.1, so you might also call it restrictive filling pattern or grade 3 diastolic dysfunction. However, we do not have a very high E to E prime, only 12.5. Good. So let me come back to the question.
So please think a little bit about that and give us your answer. Whether this patient had aortic valve replacement, myectomy, heart transplantation, alcohol septal ablation, or interarterial septal defect closure.
So make your choice. Well, we'll give you some time to answer this. And in the meantime, we'll show you how the Echo2Go actually works. Because you have the option, of course, on your mobile device or your computer or PC at home to answer. And then once you answer it, you get, we call it an emoticon, to tell you whether you're not right or wrong. We'll show you 2 examples, whether or not you were right or whether or not you were wrong. Take a look.
Yes!
So you see, we had a lot of fun also filming these Echo2Go questions, and it's just playing around a little bit to make learning a little bit more fun. But let's see what your answer is. Well, you can, of course, send your answer to us, and we'll give you the correct answer in a few seconds. Before we do so, let me go back to this case again and maybe discuss a few things that I think are also important. We talked about the issue of left ventricular hypertrophy. How do you assess it? Do you only look at it visually? Do you really measure in all patients? Where do you measure? And do you sometimes perform mass calculations?
Well, normally I use parasternal long or short axis view in some patients for measurements of left ventricular wall thickness. Normally I do it from parasternal long axis view, and I just measure in end-diastolic frame the thickness of a basal segment of interventricular septum and of the posterior wall of the left ventricle. Then we can proceed for the calculation of LV mass. Also, a very important pattern when we are talking about LV hypertrophy, whether there is a concentric or eccentric LV hypertrophy, and there is a parameter, relative posterior wall thickness, which help us to differentiate between these 2 findings.
Yes, so there's, of course, a lot of information in the thickness of the myocardium and different ways of assessing it. I guess the most important thing is you would visually look at it, but ultimately you have to perform some form of calculations with all their limitations. Let's come to the answer. And I saw that there was a pretty even distribution between the options. This was probably not such a difficult case. So the answer in this specific case is?
Heart transplantation.
Good. And why can we be sure that this is heart transplantation? It's a different heart. It's a normal heart, actually, only in a different patient. Well, there are some clues. The first clue is that we do not see any artificial valve. You see that the valve is completely normal. Now, it does not 100% exclude that the patient had aortic valve replacement, because it could also be a homograft. So this maybe might be a little bit of a limitation, but in essence, we don't see that the patient has any artificial tissue here or some prosthetic material.
Also, there is no aortic regurgitation, which is very unusual for prosthetic valve, because normally we have at least trace transprosthetic regurgitation.
Yes, exactly. This is how a prosthetic valve would look. This is a bioprosthesis. You see the struts here. They're pointing into the aortic root. This is the tissue part of the valve, and you often have artifacts here distal to the prosthesis. What about myectomy? When do you perform myectomy in the first place?
Normally, if patient has hypertrophic cardiomyopathy, obstructive cardiomyopathy, when there is significant gradient, more than 50 millimeters mercury, then we have to think how to help these patients using surgery.
Right, and if you go back to the 4-chamber view that I showed you previously, the patient does not have hypertrophic cardiomyopathy, so there's no real reason to perform a myectomy. It's sometimes very difficult to determine if a patient had myectomy. It also depends, or let me put it this way, it depends very much on how much of the myocardium was shaved away. But frequently, you would see a relatively thin basal septum, as in this example here. So this would be a patient who had myectomy and also has considerable left ventricular hypertrophy. And the same is true here. there's a basal part of the septum is missing here, even though I guess I would agree that this is very difficult to say if you don't know that he had myectomy here, right? Yeah, so this is the issue of myectomy. And it's not an ASD occluder because in most situations you would see an ASD occluder quite nicely. There's two different types of occluders here. This is a Gore occluder and this is an Amplatzer occluder. You can see the typical location of the discs here. It's kind of spanned on the aortic root here. It's an echogenic structure, and here you also see echogenic structures right here. And the key finding that it was present in this patient that indicates that heart transplantation was done was?
Well, let's have a look at the left atrium in this patient. First of all, we can see that the left atrium is enlarged, is dilated, and then on the lateral wall you can see a structure which is actually a surgical stitch. That's how the new heart has been connected with the old one.
Yes. I mean, there's different ways of that, how that can be done. In previous times, they would actually leave the old part of the left atrium and only attach the new heart with its atrium there as well. And there you would get very long atria because you had half old, half new. In this case, it was only that the pulmonary veins were implanted with parts of the atria. That's also why the atria are enlarged, at least that's one of the reasons why the atria are enlarged. But there are some other clues that would indicate that this is heart transplantation. I know this is a subtle finding, but you will see it in practically all patients. Look at the motion of the ventricle, especially during diastole. Can you see how it vigorously dilates? This is a very typical finding, and this is also one of the reasons why these patients have a very high E wave. We'll come to that later. So the motion of this ventricle is quite typical actually for heart transplantation. To be honest, I don't really know why this is the case. Is it the result of denervation? I do not know, but it's a finding that you see quite frequently.
I would also like to comment on longitudinal function of the left ventricle, and it's also important clue, not only for heart transplantation, but for cardiac surgery in general. So normally we have reduced longitudinal function. You can clearly see it visually from 2D images, but also we can see it assessing the global longitudinal strain.
Yes, the global longitudinal strain is reduced. Interestingly, you find this in many patients with heart transplantation. So the normal values of longitudinal strain after heart transplantation are lower, even though they do not have rejection, even though they do not have any problem. What we now know, though, is that if we see a decrease, a dramatic decrease from one exam to the other in longitudinal function, this might indicate that there is some form of rejection. Again, one of the potential values of longitudinal strain. So, coming back to the Doppler spectrum, this is a situation where you actually should not assess diastolic function, right?
Completely agree, because we cannot judge on the A wave. A wave is definitely abnormal because just the left atrium is not normal in this patient and there is a surgical stitch in it. So we cannot assess accurately the A wave velocity, and that's why we cannot rely on EA ratio talking about diastolic function.
Right. So when you see these patients, you will almost have all patients who either have the restrictive filling pattern, or what we used to call the pseudonormal pattern, with a relatively high E wave and a relatively small A wave. As Elena mentioned, we've got this problem of the left atrium not being functional or full functional, and I also believe that this rapid outward motion of the ventricle creates a suction. That's why you have a high A wave. But for those of you who see transplant patients, forget diastolic function. You cannot assess it, and there's, in my view, not much value in looking at it. So I guess this clearly shows that sometimes you have to use very subtle abnormalities to determine whether or not a patient had a transplant. But I guess in a clinical situation, you would agree, we know that the patient had a transplant because, after all, we can actually also talk to our patients. Good. Let's come to the next case. This is a case that I would like to call a bump. Here is the peristernal long axis view and the short axis view. Elena.
Take a look at the motion of the interventricular septum. Can you note some abnormal motion, bumping, let's say?
Well, absolutely. There is something abnormal here. You see there's a, how can you describe it? It's a rapid back and forward motion of the interventricular septum. And this is a typical finding that you would find in pericardial constriction. A finding we also call the septal bounce. There is a number of reasons why this occurs, but let me look at the other views to demonstrate what the problem in this individual patient actually is, and then I'll also give you the history of the patient, which was a very surprising history. Take a look at the short axis view though as well. You'll see there's a little bit of septal bounce visible as well here, and you can already see that there's something going on right here beside the right ventricle. Elena.
Well, here you can clearly see that something wrong with these images. And you can see a structure close to the right ventricle. I believe that you can clearly recognize that this is extracardiac structure. It's not related to the right ventricle or any other cardiac chamber. And this structure compressing the right ventricle.
I have to give you the history at this point. This is a young patient, only I think he was 30 years old, and she had an operation done, a hernia operation. And everything went wrong during the hernia operation, and she even developed septicemia, what do you call it?
Septicemia,
yep. So she had fever. And eventually what happened was that she created an abscess right close to the heart, pericardial abscess right here. And this abscess formation compressed the right ventricle. Now, in such a situation, you also have impairment of filling of the right ventricle. And what is always recommended to do in such a situation is look at how narrow the tricuspid annulus here is, and look at the color flow to see if you have turbulent flow. In such a situation, since the right ventricle cannot move outward, if the right ventricle fills, it has to also push the septum to the side. So this basically means that this is a form of external compression of the heart, which shows very similar findings as pericardial constriction, even though it is not the classical type of pericardial constriction. Here is the color Doppler that I promised to you. You see that there is no turbulent flow, which is good, so it's not completely obstructed, but the mass is quite large and the right ventricle is significantly compressed. If you look at the CT, you can see how extensive this abscess formation actually was. You see it right here, partially liquidified, partially already organized, compressing the right ventricle here. You can see that it is pretty far all the way up cranial to the level of the great vessels. And if you look at the longitudinal view here, you see the abscess formation right here, a pretty big abscess. If you look at the Doppler findings, you would normally expect in constriction that you have these fluctuations in the E-wave velocity during aspiration, which is not present here, but I think you should not rely on this finding because it's not a typical form of pericardial constriction. And you also do not have the typical finding of pulsus paradoxus. Do you want to maybe explain what pulsus paradoxus is?
Yes, pulsus paradoxus, it means that the ejection fraction and the volume of the left ventricle pumped to the aorta is different in different cardiac cycles, and normally we have different volumes going to aorta from beat to beat. Here we can see that all the curves are absolutely equal, so we can conclude that there is no pulsus paradoxus in this patient.
Yes, and there's also this phenomenon of annulus paradoxus, where normally you would have the lateral wall of the mitral annulus having more excursion. You would see a higher S wave, E wave here than in the medial part, and this is reversed in patients who have classic constriction. But this requires that also the lateral part of the myocardium is some way fixed, which it isn't, because it's a problem which is located more on the right heart of the side. What you need to have if there is some form of right ventricular impairment of filling is a dilated IVC, which is present, and then we have something down here as well. This is a pleural effusion, and this was one of the main problems she had. She was dyspneic also because she had bilateral pericardial pleural effusions and actually also developed ascites as an indication that there was a filling problem of the right ventricle. Here's the pleural effusion again. Now, I'll just sum up the case very quickly. Unfortunately, I don't have the latest images with me. I just imaged the patient a few days ago. But fortunately, this abscess is starting to decrease in size. A drain was put, she got antibiotics, and we see that the symptoms of the patient are getting much, much better. We see that the pleural effusions are gone now. There is still some degree of compression of the right ventricle, but at least not to a point where it is hemodynamically significant. At one point, I was actually opting to operate the patient to remove this abscess formation, but luckily, she made it at least until now without surgery. So I think this concludes the last case I want to show, and I think you've seen a lot of different pathologies, and you've seen the different modalities. We've talked about 3D, we talked about speckle tracking, and I do hope that you will be with us in our next webinar, and I'm sure you will see Elena again, and she'll bring with us a few very interesting cases again.
I'll definitely do.
So thank you, and have a very nice evening. Bye-bye.
Thank you. Bye-bye.